Unfortunate reality is 100% of the population develops heart disease. Low testosterone, high estrogen is actually one of the worst combinations because that really promotes central adiposity in men. Super intense exercise, especially guys that do really heavy weightlifting, bodybuilders, powerlifting, you're putting a huge amount of stress on the coronary arteries. That in of itself can actually lead to premature atherosclerosis. I really shouldn't be having to do this. If we actually had a better screening system and made the population more aware of what atherosclerosis is, early treatment could be initiated, hopefully never come see me.
Is there a current screening process that someone can do to help with that information for their own health?
Interesting question. There has been a screening test out since 2000.
Welcome to the ManLab, where we combine science and health in the pursuit of making men great again.
This is how legends are born. This is how legends are born.
Welcome back to the ManLab. So today we're going to be diving into the heart health. For this episode, we have an interventional vascular cardiologist. Impressive title. I don't know exactly what that means, so I'm going to get Dr. Arcement. Is that right again? Oh my gosh.
Dr. Arcement.
Arcement?
Yeah, that's close enough.
Okay, it's the accent. We got Dr. Arcement to speak about everything heart related so that you can make the best decisions for your health. So, Brian, can I call you Brian? Dr. Brian?
Absolutely.
Thank you very much for being on here.
Blake, let me just say,
Run us through.
This is kind of a special show for me because for those of you who have known me, Dr. Arcement was my absolute very first business partner. Kind of the man I learned almost everything I know and definitely the launching point for my career. So I was really excited to have Brian on the show. So we've been in business for going on 19 plus years now. So he was the original,
correct.
the OG doctor in this entire organization. So without Dr. Arcement and I's relationship, none of this would be here.
Wow.
Thanks. Appreciate that.
He's the
Heavy as a
vascular
crown, huh?
goat.
He's the goat.
I know he's the vascular goat.
He's the
Just
goat.
through the hospital.
So your title, I mean, other than cardiologist, I have no idea what that means. So could we run through what it is that you do, what you specialize in, so people can really understand who is Dr. Brian Arcement?
Okay, sure. So what my profession is I'm an interventional cardiologist, which means that I repair diseased arteries. So, this is the unfortunate reality of all of us. As we age, we build up plaque in the arteries. And unfortunately, most people are kind of led to believe that this is something that, hey, if you do this, if you do that, you're not going to get heart disease. The unfortunate reality is 100% of the population develops heart disease. Now, some people who are blessed with phenomenal genetics may not get heart disease until their late 90s, but the majority of us start getting heart disease in their probably early 70s, mid-70s, and people start dying from heart disease on an average between late 70s, early 80s. So this is where I come in, is people come to see me after they developed all this plaque in their arteries and starting to affect blood flow to either their heart or different organ systems, and have to go in there and repair the arteries, either going in there and cleaning out some of the plaque, but primarily putting in stents, which are metal scaffoldings, which basically open the artery up and restore blood flow to either the heart, which is obviously the primary issue that what I work with, or other organ systems like the kidneys or the intestines or the legs. So those are the major things that we work on. So when I sit there and I talk to patients about this is what I do, the unfortunate thing is that I really shouldn't be having to do this. If we actually had a better screening system and made the population more aware of what atherosclerosis is, early treatment could be initiated. People could start changing around their lifestyles and hopefully never come see me or never end up on the cath lab table or never have a heart attack or never die from heart disease.
Is there a current screening process that someone can do to help with that information for their own health?
So, interesting question. There has been a screening test out since 2000, but the American Heart Association has yet to set an algorithm for deciding when people should get this test done. So unfortunately, they have not laid this information out for primary care physicians. So if you were to go see your doctor and you were to ask your doctor, I want to get a screening test for heart disease, he would kind of shrug his shoulders and say, I don't know anything about that. Now, some of the physicians out there are more astute and have learned about this test and will send their patients to get it done, but still there's no protocol of what age you're supposed to get it done and how frequently you're supposed to get it done. Unlike what we screen for different cancers like colon cancer, prostate cancer, breast cancer, cervical cancer, we're screening for all these cancers, and these have all protocols that are set up by the Oncological Society so that patients know when they're supposed to get these tests done to reduce their chance of actually getting these cancers, or if they get these cancers, getting these cancers removed so they survive. There are zero protocols for heart disease, and heart disease still is the number one cause of death, still supersedes all cancers.
No, this is the CT scan that you.
Well, I was going to say he's just left everybody hanging.
So
I was like,
everybody-
whoa!
What is this screen?
I was like, is there something new I don't know
Everybody's
about?
paying attention. You gotta make them like, well, what is it? What is this great test that's been out? So it's actually a simple CAT scan, and what the CAT scan does is it scans the arteries and it looks to see, is there plaque development in your arteries? It's not a test to determine, like a stress test, do you have critically blocked arteries? It just wants to know, do you already have atherosclerosis? It's like when you go and look in the mirror and you're like, am I getting old? Do I have that first wrinkle yet? Well, this test tells you, have you started aging in your arteries? And the interesting thing is that we all age at a different rate. And that's all based on our genetics. And I wish I could sit there and tell you that you go to your local lab, get a blood test and says, hey, these are your genetics. This is when you're getting heart disease. You should get your scan done now. We have none of that yet. Now, maybe with AI, they'll start developing, a better algorithm for sitting there screening DNA to determine which patients are more likely to develop premature atherosclerosis or which ones don't. Right now, you go see your doctor and they look at you and they go, okay, well, your blood pressure is okay, your cholesterol's okay. Come back and see me in a year. And, well, okay, how's my heart? Oh, your heart's great. You're doing fine. Your EKG looks good. Well, an EKG is a heart tracing of what's going on with somebody's heart right then and there. And if nothing's going on, it looks normal. And you could have literally 70% plaque buildup in your arteries, have no idea. And the next time the doctor sees you, well, how you been? Well, I had a heart attack. Well, oh, wow, that's crazy. How'd that happen?
So with your expertise and knowledge, at what age should someone start taking these CT scans, and how frequent should they?
Yeah, so great question. I mean, it's really kind of based on risk factors. Now, it doesn't mean that if you have no risk factors, you should not get the scan done. Like, oh my gosh, the scan's going to harm you. Now, it is some radiation, and all CAT scans do carry a radiation risk. So it's one of the interesting things, and this is another sort of a side note, not trying to get off on the tangent, but excessive CAT scanning is one of the number one causes of cancer. So people that go to the hospital and get a CT scan for this and a CAT scan for that, and when they're CAT scanning everything, every time you come in with something, because doctors are concerned about missing something, excessive CAT scanning is bad for you.
No, they just gave you the problem to treat, which is cancer, because too much radiation.
Correct. Too much radiation, exactly.
What's too frequent?
Well, I mean, ideally, you don't want to have any CAT scans done unless they're absolutely necessary. But of course, if you go into the hospital and you've got nondescript abdominal or chest pain, and they get just a normal plain film and there's nothing there, they're going to go, well, we don't want to take any chances. We're going to CAT scan you. Because a CAT scan gives you a wealth of information about the internal organs of a patient that a regular x-ray film is going to miss. So let's say you go into the hospital, every month with the same thing. They're just going to CAT scan you every month. Unfortunately, they don't sit there and tell you in a disclaimer, by the way, excessive CAT scanning is going to lead to cancer potentially. They don't tell you that stuff. But I'm not obviously telling patients not to go get studies done. This is just a reality of saying, hey, this CAT scan that we do for screening arteries, people may say, well, wow, I want to get this done every 6 months. I'm like, no, that's a little crazy. There's no reason to scan your arteries that frequently. And the most important thing is you want to start scanning the arteries when you think that the arteries are going to be clean, not excessively early, but early enough that you start trying to make sure that you're not going to miss a first signs of atherosclerosis. And then you set up a protocol for screening those patients, typically every 5 years with the CAT scan. So as far as when to initiate doing CAT scanning, men unfortunately have a higher rate of atherosclerosis than women do. So we always scan men typically 5 years earlier than we scan women. If you have no risk factors for heart disease, let's say there is no family history, you've got normal blood pressure, no diabetes, your cholesterol numbers are okay, then we tell men the first CAT scan you should get done is at the age of 50.
Like a prostate exam.
But it's like a prostate exam, except a little more in depth.
He does it,
can I
he does
say-
it recreationally.
we in our business in the hormone replacement, you tell most of our clientele, especially if they're looking to go on to HRT, and I think it's like around 45. I just turned 45 this year. It's actually the second time I've done it, obviously being your partner. I kind of heard and listened to this over the years. I did it my first time at 40. I just did it about 2 months ago, 45. I think it's one of those things that based on blood tests, cholesterol levels and dietary advice,
Correct.
and I think maybe using of hormones, which I guess I want to get into in a second.
Correct. Yeah, we'll get into that.
That my potential risk factors were more great than the average person because I was having a lot of more of a carnivore style diet, which I know you're not great. We'll
discuss that.
We'll discuss that.
They will talk about that.
I openly have talked about my use of steroids and hormones in the past. So of course, that's a higher degree of risk. And so I think that, people need to kind of dissect what they are and determine if that risk is great enough to take that risk in the potential risk of cancerous development. Now, let me ask you, if you have a female, for example, who has a family history of breast cancer, she may not have ever had breast cancer, and now she's at that age of 50 years old or 55. Do you reconsider that risk of kind of opening the door to breast cancer in order to potentially limit the risk of the heart disease? Like, how much do you
interesting question. The amount of radiation you get with a CT heart scan is actually not that terrible.
Nuviva Medical Weight Loss has helped over 50,000 men and women in Florida lose over 500,000 pounds in body fat. Now, there are wonder drugs out there like Semaglutide and Tirzepatide, but it's important that these tools are used properly and safely with the correct guidance, because that guidance is what will help you make sure that you're losing that unwanted body fat while keeping the lean muscle mass. Nuviva Medical Weight Loss has over 10 clinics statewide in Florida with expert coaches who are with you the entire way, helping you with any habit adjustment, large or small. The secret behind Nuviva's continual success with their clients is their in-office expert experience. You will speak directly with a support coach, and if you have any questions, you will get immediate answers. If you are struggling, you will get immediate adjustments or pivots that will keep you on track with your goals. And what's great is you can choose the route of your weight loss goals. So if you just want to take diet adjustments and some supplements, you can do it. However, if you want to go a little bit of a stronger, faster approach and use semaglutide or tirzepatide, the Nuviva expert coaches can also help you along the way with that as well. So if you have a lot of pounds to lose or even just a few pounds and you know that having some support with an expert coach will get you there faster, contact Nuviva at either nuvivaweightloss.com or send them a message on Instagram at Nuviva Weight Loss and mention the ManLab for a little perk. That is Nuviva, Nuviva weightloss.com or at Nuviva Weight Loss on Instagram. So hit up Nuviva, get an expert coach, get that support you want, and let's get you feeling amazing again and lighter again. Let's get back to the show.
It's about the same effectiveness of getting about 10 chest x-rays. One of the interesting things about breast cancer in women is they get a mammogram done every single year. So you're radiating the breast every single year. And they've actually had this theory that, excessive mammograms actually increase your risk for breast cancer. And that's why they say, get a breast ultrasound instead, because ultrasonography is zero radiation. They're using ultrasound waves. But so that whole idea of like saying, if you're getting a CT heart done and you're basically CAT scanning the breast, does that increase your risk? Probably a minuscule amount, but the really infrequent number of times you have to get a CT heart is pretty minimal. And so kind of back to talking about, when you should get this done. So if you're a guy, you have zero risk factors, age 50. If you're a woman, zero risk factors, age 55. Those scans should come up zero. And that's what you kind of expect. If you have one risk factor as a guy, you should get your first scan done at age 45. And one risk factor could be things like high cholesterol, high blood pressure, you smoke cigarettes.
Obese.
Obesity, surprisingly, in men, even though it is a risk factor, we don't sit there. it's not actually listed as one of the major cardiac risk factors, which is interesting because we all know that visceral fat in men definitely does correlate with higher rates of atherosclerosis. It's just not one of the major risk factors that we list as far as, hey, you should get a CT heart done. But most guys that have enough central adiposity, they're hypertensive. You know, they might be borderline diabetic at that point.
You're not going to have the. You're
They're not going to have normal.
They'll
Yeah,
have the
they're going to have at least
cofactors with
one.
that.
Yeah, they have at least
So like
one
my
factor.
level was like, I think my number came back at 16 or 17. And I know you kind of said, oh shit, that's
Well, it's a little high, but
That's not great.
one of the interesting things about arteries and development of atherosclerosis, and this is kind of an interesting point about exercise. So super intense exercise, especially guys that do really heavy weightlifting, bodybuilders, people that do powerlifting, you're putting a huge amount of stress on the coronary arteries. That in of itself can actually lead to premature atherosclerosis because you're actually damaging the arteries. And that's why they really kind of say you should do more moderate range exercise and not really push super heavy weights. But again, that issue of, well, why did you develop that little small amount of atherosclerosis when you're incredibly healthy, even though you consume some, sometimes more animal fats than you probably should? That would be more of a genetic component of the arteries. So that region in your coronary arteries that develop that atherosclerotic plaque is just not as resistant to damage and inflammation as other areas are. And even though if you were to do a cross-pathologic section of the coronary arteries, they look the same as other arteries like in your arm or in your leg. There's no real difference as far as the anatomy goes. And it's, well, why are the coronary arteries sometimes more susceptible than other arteries? Like it's almost unheard of to get atherosclerosis in the arm arteries, where it's much more common to get it in the leg arteries. And that probably has to do with the amount of shear stress that occurs in the arm arteries compared to the leg arteries compared to the coronary arteries.
Does something to do with the movement too? Like you're constantly swinging your arms.
Something like that,
People are very
but,
more
I
stable.
mean, you
granted,
gotta
you walk
remember-
a lot, but you also sit a lot too.
Yeah, but you got to remember that when you're standing, the actual pressure in the leg arteries is much, much higher than the pressure in the arm
It has to
arteries.
pull all that blood back up out of
Well,
your
it's
feet,
because
but-
of just the column of water, because we're just a big column of water. And so the pressure at the very bottom of the column is much, much higher than the pressure at the top of the column. So when you're standing all the time, the calf arteries are under more stress than like your arteries in your arm are. But, that being said, it still has to do with the fact that for some reason, the arteries in the arm are just more resistant to inflammation and damage than like the arteries in the legs and like the arteries in the heart. And we also see this when we actually, perform heart catheterizations on patients. Sometimes we'll actually go in there and I'm like, wow, your arteries in your heart are normal, but you have peripheral atherosclerosis. And again, it's a genetic issue where their arteries, forever in their developmental process, were just more sensitive to inflammation and damage than the coronary arteries were. I'm going to take a break and get some water.
No way. So I've got a question around. I'll pull this up. Sorry, there was one that I had. So you mentioned about obesity is not really one of the leading factors or like the concerns.
Well, it's not listed.
It's not listed.
So when you talk about, and these are protocols as far as risk factors that are set out by American Heart Association. Obesity's on there, but it's actually kind of down the road as far as what are the primary causes. So number one cause is genetics. Second is high blood pressure. Third is diabetes. Fourth is smoking. And then fifth is like really bad lipids. I mean, and depending on where your lipids are at, it could actually move it up in the scale. Obesity is after that. And it's not listed as like, this is one of the major risk factors. What's interesting is obesity in women is much less of a risk factor than it is in men because most women carry their body fat peripherally. Now, some women genetically will actually carry their body fat the same way men do. They'll have central adiposity where they'll have that truncal obesity, just like a man would. But you look at most men, when men get overweight, it's all in their gut. And that's all visceral fat. And unfortunately, the fat that we actually store internally around our organs, actually promotes the liver to produce higher levels of aggressive LDL cholesterol. And it also produces more what we call inflammatory cytokines, which are little proteins that actually inflame different areas in our body and can really cause a lot of damage to the arteries.
And that's why testosterone deficiency is really a harmful thing in men, because that leads to visceral fat, right? And
Absolutely.
So, of course, therapies
low testosterone, high estrogen is actually one of the worst combinations, because that really promotes central adiposity in men. And so, correct. So if you have low testosterone and high estrogen, it is extremely difficult for you to actually lose that body fat, even if you're following actually a healthy diet. And what's interesting is, and I always tell my patients this, it doesn't matter how you got that visceral fat. If you got that visceral fat from eating avocados, olives, nuts, it's still visceral fat. It's no different than the fat you got in your abdomen from eating bacon and pork and steak. It's there, and it causes the exact same damage. So obesity is obesity, whether you got it from eating healthy or eating bad. Now, yeah, I mean, if you were to sit there and have two different cohorts, and one set of cohort got obese from eating nothing but super healthy fats, another cohort got obese from eating nothing but really bad fats, I can almost guarantee the bad fat group is going to have high rates of atherosclerosis because of all the inflammation that occurs because of the types of animal fats they're consuming. So it actually causes inflammatory damage to the arteries, in addition to then developing the visceral fat that leads to the higher rates of these inflammatory LDL or bad cholesterol particles. But I know we got off on a tangent back to the scan stuff. So we kind of already had that stabilized, where no risk factors, age 50 for a man, age 55 for a woman, one risk factor, and it could be any of those risk factors we listed. Age 45 for a man, age 50 for a woman, two or more risk factors. Then it's age 40 for a man and age 45 for a woman. If you have multiple risk factors, especially if you have a really genetic propensity where you had first-degree relatives that had premature heart disease, like before the age of 60, then we recommend, honestly, for men, getting your first scan done before the age of 40. And sometimes we tell them, listen, if you're 30, get your first scan done.
Yeah, wow, that's pretty young.
So now that we've done this test, and then let's say you do find somebody, and granted, I'm relatively concerned about myself, short of changing of diet, which I know we have a long talk about diet coming up here in a minute, but therapies that are currently offered, what do those look like now? So ways to maybe, I don't want to say fix the damage that's done, but prevent it from continuing to happen? Or is there a way to fix the damage that's done? Is there a way to reverse damage that's been out there? So what are the options now?
Yeah, so great question. And this is one thing people always ask is, well, I've already got this plaque. Is it like cancer? I'm kind of stuck with it. And fortunately, no. Unlike cancer, you can't go out and eat healthy and make the cancer just go away. But atherosclerosis, you can. So all atherosclerosis is a buildup of LDL or bad cholesterol. And we call LDL bad cholesterol. It's not actually bad. There's many uses in the body. It's like the primary basis for all of our hormone-based production. So like our testosterone, estrogen, progesterone, adrenocorticotropic hormone. So all those are all based on LDL cholesterol. Your cell walls are made up of LDL cholesterol. Your neurons, the cell lining of your nerves, your brain, all LDL cholesterol. So it is an important part of our bodies. And people think, oh, why do we even have LDL cholesterol? Yeah, because it serves a major purpose. So the body actually needs LDL cholesterol, but it just doesn't need that much. So you start building up LDL cholesterol in the arteries. So it's like a storage site for your LDL cholesterol. Now, the body always produces as much as your body needs, and in some people, obviously, you produce way, way more than your body needs. So if you suppress your LDL cholesterol and reduce inflammation in the arteries, your body will actually start scavenging and start pulling LDL cholesterol out of the arteries, because it actually needs LDL cholesterol and take it back to the liver for processing for the rest of the body. So you can actually remove LDL cholesterol and actually heal up the arteries. Now, the earlier you start doing this, the better chance you have of actually completely healing the arteries. Now, in the aspect of like the way the arteries look on the calcium score, and that's what it's called a heart calcium score. What we're actually looking for is calcium deposits in the atherosclerotic plaque, and that occurs in, I'd probably say 90% of plaques that develop, where the body will deposit some sort of calcium in the arteries. And what that purpose is the calcium actually stabilizes that plaque. It helps to reduce the chance of that plaque actually becoming more friable and potentially rupturing And of course, if a plaque ruptures, you're exposing your normal blood flow to this fatty cholesterol material, which as far as your body's concerned, that's no different than injuring yourself, and a clot starts to form in there. And of course, if you have a really large plaque that's borderline obstructive and that ruptures, a clot forms suddenly that's large enough to obstruct the artery, and that's a heart attack. But you can have plaques rupture, occasionally that just form a small clot that then dissolves on its own and goes away. But once that calcium is in the artery, it does help to stabilize that plaque and reduce the chance of that plaque rupturing. But it's not like your body's going to go in there, remove the LDL cholesterol, and they go, hey, calcium, come on out. It's time for you to leave too. A lot of times the calcium stays in there. So sometimes even though patients have really improved their arterial health and they've really removed the LDL cholesterol, a lot of times the calcium score will stay the same. Occasionally, especially if we have more of a soft fatty plaque, and the softer, fattier plaques are the more plaques that are actually at risk of causing heart attacks than the hard calcified plaques. So these soft fatty plaques, as you actually start removing more LDL cholesterol, the body will actually put some calcium in there as you're pulling LDL cholesterol out to start stabilizing that area. So sometimes when we start getting more aggressive with patients and we start more aggressively treating their plaques in their arteries, the calcium score will actually go up somewhat. And so patients think, oh my gosh, my arteries have gotten worse. I'm like, well, not really. They've actually become more stable, and it puts you at a much lower risk of actually having a potentially life-threatening heart attack to occur. So that's why
Because
it's
the
important.
calcium isn't really the culprit of the damage. It's the
Correct.
LDL that potentially is getting dislodged and creating that.
Correct, yeah. So calcium is just there to actually stabilize the arteries, and heavily calcified arteries don't typically suddenly kill people unless the plaque where the calcium is at has become so obstructive that the blood flow through that area is not enough to maintain the normal oxygenation for the heart muscle. And that can actually lead to sudden cardiac death, something we can get into later. But it's the fatty plaques that we get really concerned about, and that's where we really want to start shrinking up those plaques as much as possible. But when we look at a heart score, we're just looking at to see, do you have calcification and how much is there? And that helps us to decide how bad your arteries are at that point in your life, and then how aggressive do we need to get. Now, to sit there and say, hey, because patients get obviously very excited the minute they find out, oh my gosh, I'm mortal, I have heart disease, this is bad. They want to check their arteries like every 6 months, like, I want to see if my arteries are getting worse. I'm like, that's not necessary, because plaque in the arteries does not develop rapidly. It took years to get there. It doesn't all of a sudden get worse that rapidly. So usually I tell patients, once we first start identifying they have atherosclerosis, usually we check it once every 5 years under aggressive management. And our goal when we first start initiating treatment on patients based on what their calcium score is and also what the risk factors are is how low we want to get that LDL cholesterol. So, the current standard is they want people's LDL cholesterol on average below 100, which I tell you, probably maybe 20% of the population might have an LDL below 100.
Is that extremely low, though? Like, what would you say is because you said we needed to have a certain amount.
Yeah, what is the
there a
amount of
healthy
LDL
amount?
that the body typically needs without excess?
Because I know that once humans tend to find something that is either bad or good, we want more or less. And
They go to extremes.
It's a fight to
Correct.
zero, or it's a fight to infinity. Versus as the body operates as a sort of ebb and flow situation. So, I've heard, and you can correct me on this, but as soon as modern medicine found out that LDL cholesterol was an issue, there was kind of this race to theoretical zero. Do you believe 100 is maybe overkill, or do you think that there is like a certain number that we should be, not fearful of, instead just thinking, all right, this is a safe amount?
Yeah, so 100 is definitely not overkill. 100 would be more than enough LDL cholesterol for your body to produce everything that it needs. And this is one of the other tough things about cholesterol when patients go in and they get their lipid numbers done. When you're measuring the LDL cholesterol or the HDL, you're actually measuring the weight of the sample. So it's not actually saying this is how many number of LDL particles you have. This is just the weight of your LDL in this blood sample. So LDL is actually made up of particles, and there's 7 different particle types. So the larger, heavier particles are actually less atherogenic. They actually don't do any damage to the artery. They just kind of bounce around and cause no harm. So you can actually have patients that come and have an LDL of 150, but it's all made up of large, heavy, bouncy LDL particles. These cause no damage at all, and so you almost really wouldn't have to do anything. Even if you check a heart scan, I'm sure it'd come up 0, and you go, okay, fine, great. You just check those patients, every 5 years, and you don't actually initiate treatment on those patients. Conversely, you could have a patient that has an LDL of 90, but it's made up of all of the extremely small, super aggressive, pro-inflammatory particles that cause lots of damage. And so you may need to get that patient's LDL from 90 down to less than 50 to lower the particle number significantly to cause less damage, especially if you get the scan done and they already have atherosclerosis. And this is why the scan becomes so helpful for clinicians. Instead of just guessing when somebody comes in and they say, hey, doc, my LDL is 160. Oh, you need to go on medication immediately.
Right.
It's like, that's just not true.
Is there a lot
is
of
the name?
doctors that just go based on the number? And how
The
could you
unfortunate-
mitigate?
The unfortunate reality is that, yes, that's actually the standard of care.
Yep.
That if you come in and your LDL cholesterol is 160 or higher, they are automatically going to start pressing you to go on statin medications.
Yeah.
Before, what is the name of that? The 2 different type of cholesterols that
The LDL and
like it's
LDL.
ApoB or ApoA. Like, what are the differences when you're looking at these blood tests? If I want to know of those 7 different type of LDLs, which one I actually have,
Well, it's
and
actually a
is there a blood
particle
test that
size
can help
test.
you
Correct.
figure that out?
So that's what Jeff said. It's a particle size
test.
test. So ApoE and ApoB, those are basically just transition particles that helps to actually transport your LDL or HDL particles.
So the proper thing to really know how high of a risk you are is not just do a fasting lipid. That's kind of a 60,000 foot approach to see if
Correct.
my LDL is high or not. But ultimately, what we're hearing now is that that's kind of doesn't matter. So what really should matter is this particle size test, right?
Correct. Yeah. And so the particle size test is where you really go and you investigate your LDL cholesterol, so you know what the genetics of your LDL cholesterol is.
And so the smaller it is, the higher risk you have.
Correct.
The bigger
smaller is the
particles,
higher
the
risk
less
it is.
Yeah.
And so what they'll do is they'll actually give you a particle size dynamic, and then they'll give you a total particle number. So you know how many particles you have, and then you know roughly what your particle size is. And that helps to determine what the risk of your LDL cholesterol is. Now, does that mean that everybody with small LDL particle disorders gets atherosclerosis? No, because there's also the genetics of the arteries that come into play. And again, there's no test, unfortunately, to tell you what the genetics of your arteries are, how resistant your arteries are to inflammation. And that's one of the problems, again, we currently have. And this is where the heart scan comes in and it's so helpful, because it takes the guesswork of out trying to figure out, okay, well, yep, you got a small particle disorder, but do you have resistant arteries, or your arteries more susceptible to inflammation? So you get the heart scan on those patients, and hey, your arteries are clean. Great.
And that's something that, we at the clinical side really speak to our clients about. Like, we see that they have the elevated LDL and cholesterol that may be off the chart, but then you're always recommending go get the CT scan, because then the question is, no matter how high this number is, let's see what damage may or may not have been done. And if you have no
Correct.
damage, then laissez-faire, like enjoy your life, like continue to do what you're doing. But if you have damage, it's time to evaluate what options you have to either reverse that or potentially fix it. And that's, I think, what the objective of us recommending these tests, and not just being a pain in their ass and saying, hey, go do tests just because it's fun to do. And
Correct.
And guys, just for your reference, like here in Southwest Florida, this is an easy test to go get. You go into Radiology Regional, you actually ask for it. It's about $100. You don't need a doctor's prescription. They will literally let you do it right there on site, and they send you the result. In different cities, different states, I've heard the rules are different. Yep. It's $100 out of pocket at Radiology Regional. I think there's 6 or 7 locations down
It
here.
was like $73, but there's
inflation.
They do have specials.
Yeah.
Actually, they do. They will run
So-
a special. And I wish that Radiology Regional was more active about educating the population, but really that's the job of the American Heart Association. And part of the reason why Radiology Regional is not going out there and having banners put up everywhere is
They're
because
not making money at $73.
well, I mean, it's not that they make. I mean, literally, once the CAT scan's paid for, they're making plenty of money. I mean, they're just running people through at that point, just cha-ching. But regardless, I mean, it's still inexpensive. But the problem is that we don't have anything out from the American Heart Association or the American Medical Association telling everybody you should get this done. And so people see this scan and, it's like, well, they go ask their doctor, and then they're like, well, what do I do? Do I get the scan? Do I not get the scan? This is part of the reason why they're not really heavily advertising about it. Now, if you were to go on their website, it gives you a wealth of information about what the scan is, and what the meaning of the results are. But ideally, we still kind of would like patients to go in, have a candid discussion with their physician, go over what their risk factors are so they can decide when to get the scan done. Because if you're just a layperson and you're like, oh my God, heart disease, well, I mean, you might start having people getting the scan done at age 30 that don't need to get the scan done. And even though
overdoing it too,
correct.
People that are hypochondriacs and walking in every month, do it again.
Correct. They're coming back every year because they're so nervous about getting atherosclerosis, or they had a scan done and it's positive, and now they're freaking out. They're so worried it's going to go up in the score. So there really needs to be some type of control over this. And even though, like Alex said, you don't need a prescription here in Florida, we want people to understand that you really need to have a discussion with your physician about this, about how frequently you should get it done, and when you should start getting it done. Because even though it's not that much radiation, any radiation is potentially detrimental. And so we always try to advise patients, you want to minimize your radiation exposure as much as possible. I mean, most people don't realize you walk outside and you get radiation. You go in a transatlantic flight, you get a ton of radiation. Literally, a transatlantic flight is almost close to getting a CAT scan. That's
what, while you're on the airplane, or you mean when you walk through the thing at TSA?
Right. That's a good reason. Actually on the airplane. Because you're up at a much higher altitude, and the cosmic radiation just goes
right. So are
right
pilots more susceptible to getting cancer because they make that flight all the time?
I don't think I've seen any studies showing that, but it just goes to show you that there is radiation out there.
So you're telling me I get the equivalent of a CAT scan like 4 times a year?
I mean, possibly. It really depends on how much.
What about a flight to Australia? Because that's like 15, 17 hours in the air.
The higher you are in the atmosphere, the higher up you are, the more potential radiation you get. Wow.
Find out if you may have low testosterone for free with the ADAM test. Now, sometimes it's a little bit nerve-wracking to go into a clinic to get a full blood panel to find out your hormone levels. And sometimes you might just want to sort of kick the tires just a little bit. If you are that person, the ADAM test is for you. All it is a couple of questions that are completely non-intrusive, non-invasive, that will help give an indication to you whether you may or may not have low testosterone. And the best part is the ADAM test is accurate up to 88% of the time. So for something as simple as a questionnaire, that is a very high number. Now, if you want to make use of that, you can do it online right now. It takes less than 30 seconds to fill out, and it is at bit.ly/free ADAM test. That's free ADAM test. Now, if you don't want to remember that, the link is in the description of wherever you're listening or watching this podcast. And then after you've filled out the questionnaire, you will now have a better idea of whether you may or may not have low testosterone, and if you need to take the next step, which is a detailed blood panel with a clinic such as T Clinics USA. So again, to make use of that, go to bit.ly/free ADAM test, and let's continue to making men great again. Let's get back to the show.
When you go on these cholesterol fighting medications, these statins, right? Now we see these people's blood tests go from having a elevated LDL and total cholesterol now into like what looks like remarkably low, and they think I'm doing great. My thought goes to what you said before is like, but now you're choking the body of this like great thing that does all these great things, right? Cholesterol is super important in our ability to create our hormones that we all know to be so powerful. Create cognitive function and make your brain function at a higher level, vitamin D processing. So like to me, I'm thinking, shit, why take a medication that if I don't know I need it, because I didn't do this CT scan, I didn't do this particle size scan, why am I just crashing this crucial hormone, this crucial hormone inducing thing, cholesterol? Why am I depriving myself of this? And is there any data that says maybe a statin is probably the accelerant to cognitive decline, Alzheimer's, hormone deficiencies, osteoporosis because of the lack of testosterone that's being created by the body of men and women? How much are these statins responsible for those other things? So you're saving yourself from potentially heart disease, But then are you potentially opening the door and creating these other problems that plague a lot of people?
Yeah, excellent point. An unfortunate reality is all medications have a risk and benefit, and statin drugs definitely have a risk. It's not like statin drugs are risk free, where hey, you take them, now you're not going to get heart disease because your cholesterol's super low, and that's it. You're doing great. Most patients don't have any issues with statin drugs, but you never, ever want to prescribe a patient a medication unless you 100% know it's going to be providing benefit. And if you're blindly giving somebody a statin drug just because their cholesterol is high and you haven't done any further studies to prove that that cholesterol is actually causing harm, well, then you're actually causing harm because you're giving a patient a medication they didn't need to begin with that potentially could have some serious side effects. And one of the major issues with statin drugs, and it's proven it can cause cognitive issues. Now, whether that is due to direct LDL lowering or whether that's due to an effect of the medication in the brain, we don't know. We just know that if you look at a cohort of patients that go on statin medication, some of them will start complaining that they're having cognitive issues. And if you lower the dosage of the statin drug, sometimes their cognition actually improves back up to baseline again. So it's actually a really tough, call. And unfortunately, statin drugs are still the cornerstone of management for heart disease. And we talk about, you take a statin drug and people are always, this drives me crazy. They're like, oh my gosh, but this might do this and it might cause that. I'm like going, we have an option of dying from heart disease or having some side effects. What would you rather have?
Okay, so with that being said, now let's say I am on a statin because I really want to avoid heart disease. What else can I take to avoid those problems? I know coenzyme Q10. I know vitamin D potentially.
bergamot.
I know potentially considering hormone replacement, to keep my testosterone hormones up. What would you advise to people who are being on these statins or have been on statins to voluntarily add into their regimens? Should they be on fish oil, EPA type of fish oils? Like, what is the supplement regimen that if I was sitting here going on a statin that you're saying, Alex, I know your lifestyle. I know you want to stay in good shape, cognitively sharp. I know you're cool with the supplement regimen. Here's my things to take because you're taking that. Like, your body's deprived of this because of the statin potentially. So add the following in order to help avoid the inevitable or the potential inevitable.
There's two things out there, and you already kind of hit on them as far as protecting yourself as much as you can from statin side effects, and that's CoQ10 and vitamin D. Outside of that, there's not like there is something else that's going to block statins from causing problems. Now, there's lots of nutraceuticals. We can go into a long nutraceutical talk about all the supplements out there that help to improve cognition, that help to block inflammation, that help to protect the liver. Those things have benefits. And of course, if you're having potential issues with cognition from a statin drug, then we definitely recommend that you go on some of these cognitive supplements. If you're having liver problems, which is one of the issues with statin drugs, there's always a potential chance for liver damage. We always recommend you go on Silmarillion, which is a liver detoxificant.
What's it called?
Milk thistle. Silmarillion.
Okay.
Yeah.
So just to be clear, so in case anybody missed that, so coenzyme Q10 and vitamin D.
Correct.
And obviously we always talk about vitamin D as a D3 plus K2 in order for it to be highly absorbable. Fish oil, because I know you and I have spoke about the use of EPA specifically. High in omega-3s, like how key of a role will that help with?
Well, those actually don't help with protecting you from statin side effects. So omega-3s, obviously they're a essential fatty acid. Your body does not create omega-3s. You actually have to take those in. You can't get them from, just regular processed foods. The primary source is fish and some nuts and flaxseed will have omega-3s in there, but our primary source is seafood, getting omega-3s from the sea. But the omega-3s themselves, they are anti-inflammatory, but the primary omega-3 that we always really kind of talk about is omega-3 EPA. But unfortunately, you just can't get omega-3 EPA isolated by itself in nutrition. It's always comes with DHA. And DHA is important. I tell my patients DHA is sort of like vitamin A. You need a certain amount of vitamin A, but too much vitamin A has been proven to be detrimental. The same thing with DHA. Too much DHA might actually increase your risk of cancer. But DHA is super important for cerebral function, brain development in children. So you need DHA. This is a certain amount. But EPA isolated is actually an outstanding anti-inflammatory. And they've actually made a prescription drug from it because they found that, wow, EPA is so effective at blocking inflammation they found that it reduces heart disease risk by 25%, which is getting actually close to where statin drugs actually reduce heart disease risk by about 30 to 40%.
Yeah.
Why can't you find it isolated?
It's just the way it is in nature. It's always with DHA.
Lavazza.
Carlson makes those
Well, actually,
EPA
Lavazza
gems.
is actually a combination of EPA and DHA. So Lavazza is like inexpensive fish oil.
Yeah.
Vasipa is actually the prescription pure
Well,
EPA.
that Carlson company makes those EPA gems.
And you can, correct.
Yeah,
and that's, Alex is 100% correct. You can get pure EPA over the counter. You have to actually look for it. There's only a couple places that actually make purified EPA, and it's a little pricey because they have to isolate the EPA away from the DHA. People always sit there and think, oh, I'll just take a ton of fish oil. I'm like, well, what's interesting is as you increase levels of DHA actually blocks the anti-inflammatory effects of EPA.
Right.
So you take a ton
and that's
of
the
fish
problem
oil.
with the shitty fish oils. They're
Correct.
50/50s or 70/30s. So
Well,
you're
that's big key
and
point.
now,
Yep.
and a lot of it's rancid, and a lot of it converts, and there's a lot of issues with fish oils. I think obviously from a economical standpoint, it's the word fish oil isn't. All fish oil is not made the same.
Correct.
I read a lot of
100%.
studies about kind of the human race as a whole. Like you look at the coastal people that were up in the Nordic lands, and they had these ratios of 20-1 omega-3 to omega-6, and the modern American was 20-1 in the other
Opposite
ratio,
direction.
20-1 omega-6 omega-3, and that's why we have so much inflammation. That's why we have so much heart
Yeah.
disease.
Omega-6 and omega-9, are both
Really bad.
pro-inflammatory.
Yeah, so we have all this
Chicken's high in
inflammation.
omega-6, isn't it? I've heard chicken's
Yeah,
pretty
because
high
they
in
eat a bunch of
omega-6.
grain bullshit, and not farm-raised salmon, same
Tilapia.
thing. Yeah.
Farmer's tilapia is like the
Anything
worst.
that's like
It's like
artificially
Baz eating
stimulated for
bacon.
growth, right?
What's your recommended maximum cutoff for DHA consumption?
So usually it's around 1 gram is about all you need for DHA. 2
And
grams
that's
is
per
max.
day?
Yeah, 2 grams is definitely max.
Yeah.
I definitely wouldn't ever recommend anything over 2 grams ever.
And that's of the DHA component within the
Yeah, so this is one of the
fish
tough
oil.
things, like Alex was alluding to. When you go to the store and you want to buy fish oil, oh, hey, fish oil right there. And you just grab it and you start taking it.
And usually
you don't
30%
look
of
at
it's orange juice anyway.
No, but honestly, what happens in the supplement world, and I see this all the time, is people get kind of in this mindset that the more healthy shit I take, the healthier I'm getting. And to be honest, a lot of these people are actually putting themselves in a worse off
Correct.
position than ever
Overdoing
doing it at all.
different supplements,
The doses and the poison and the product themselves are not what they think they are. And they think, oh, I went to Costco and I bought some fish oil because I know Dr. Arcement on that podcast said take fish oil.
Right.
Meanwhile, this shit is garbage. And now what you're doing is you're increasing the ratio that's pushing out the good stuff and it's increasing the bad stuff. And so you really want to be careful if you're choosing to go down the path of supplementation. Talk to people who know what they're doing to give you the regimen and the quality of product. And, definitely we spend a good amount of time, probably not enough time, because this conversation could go on
Sure,
hours and hours and hours, figuring out those proper products for people's particular incidences. And I do think supplements have their place in medicine.
Oh, absolutely.
I don't think they
Yeah.
take the place of medicine. I think that they definitely have a very
Well, it's a marriage. At
cohesive
least in my
relationship.
mind, it should be a
Yes.
marriage. Unfortunately, in complete medical society, they really discount supplements. And
They do.
and they just recently discounted.
Big Pharma doesn't love the fact that you can buy stuff that's over the counter to prevent
Boy,
it.
let's not even open that can of
Yeah.
worms. So we're here for hours.
Before we jump to the next thing.
And I
Oh, sorry,
apologize.
you
Let me just specify one thing quickly. For patients that do go in and you go to the store and you want to get some omega-3 fish oil, turn it over, look at the back of the bottle, and what you want to look for is a ratio of 2-to-1. You want 2 times as much EPA as there is DHA. And if it's not in that ratio, go find something else. So you have to be savvy.
Most of them, they're the other way around.
Correct.
Yeah.
So you have to be savvy about looking at your fish oil because, it's just like Alex said, there's a lot of crap products out there.
And then what about in the traditional American diet? How much DHA is being ingested versus EPA if you're not a heavy seafood user? So then does that ratio come into the kind of daily consumption ratio you should factor in? And is that why? Because I figured in my dietary structure, I don't take in much EPA because I don't eat a lot of seafood anymore. So I actually just take only EPA because I know I take in DHA from other sources outside of my simple supplementation. So even though that's a 2-to-1 ratio in that bottle, in my diet I may be 3-to-1 or even 3-to-0. So I have to kind of balance that out in what I think is I take straight up EPA.
Yeah, I mean, you still should, make sure that you're getting in some DHA because DHA is for cognitive maintenance, and it does help with, memory and cognition and the aging brain.
I'm so forgetful.
Yeah, so I mean, and what's interesting is that when you look at the Inuit tribes, the Eskimos, they consume just massive amounts of omega-3s because of their diet. Even though they're getting tons of DHA, for whatever reason, and they've kind of shown this in studies, they don't have any of the bad effects from DHA that you get from supplementation. Now, what the reason, I have no idea. But they've just looked at this in a study showing that, excessive consumption of omega-3s from those type of people, and of course, Japan, they consume tons of seafood, same sort of thing, lots of omega-3s. They just don't see the bad side effects of too much DHA like you can get from supplements. Why? We don't know, but that's why we always...
Probably a processing
Well, and that's
situation.
also
Possibly,
it's
yeah.
an impossible test, right? Because people who are using a lot of supplements are probably having a lot of other inflammatory food choices that these Eskimos are not
Potentially,
probably
yeah.
eating or aren't present with the pollutants and processed food shit that we eat here in America. They're probably not having fast food and who knows what else that we
sitting on their
ingest.
iPad.
The best natural source of omega-3s is actually sardines. People are like, ooh, sardines. Oh, my God.
Man,
But
I love
it's actually
sardines.
the
I'm
best.
I'm good. I
I actually love sardines, too.
We
too.
played a game in Venice where I was trying to stomach one. Couldn't do it. 1
I
hour.
love
1 hour of
anchovies and
trying.
sardines.
Literally,
man, I could eat 'em.
is they're super inexpensive. The other great thing about sardines is because they're so short-lived, they almost have no heavy metals in them. So very low in heavy metals, very, very high in omega-3s. So it's a super cheap way of getting natural
You do a
omega-3s.
36-degree ice bath, I'll do sardines.
Deal.
You got to know how to. Actually, they have some smoked sardines at Publix, which are
Yeah,
outstanding.
you
They're
get some from
delicious.
Spain that are amazing.
Yeah,
I mean,
you don't have to get
or
ones that are
Portugal,
like
sorry.
greasy and all fishy tasting.
I got full blown. Like,
You got the full blown greasy fishy.
I mean, look,
fishy-
it was Italy, so
Right,
They
yeah.
gave me the worst of the worst.
the worst of the worst.
Just on the last thing on cholesterol, so you touched on LDL. There's a lot of studies that are coming out, and I'd love to hear your input about HDL. Mainly it's focused on carnivore diet. Now, this is outside of carnivore diet, but usually carnivores have a higher level of HDL cholesterol in their system.
True.
Which
Yep, correct.
most doctors would see that and have a heart attack themselves. But they're finding that these studies are finding that there's the HDL, it doesn't matter how high it gets, it's not really a problem or a concern. What's your take on that, and what have you seen?
Is
from that?
HDL truly the healthy cholesterol?
Well,
everybody thinks it is?
so HDL is what we call our protective cholesterol. It actually has antioxidant properties, anti-inflammatory properties, and it's also the conduit that your body utilizes to actually extract LDL out of the arteries and actually pull it back to the liver for processing. So HDL actually helps to remove your LDL. Now, unfortunately, just like LDL, there are HDL particle sizes, and actually small HDL particles can actually be completely ineffective and actually provide no benefit, as opposed to the large HDL, which is actually very effective. Now, back to your comment about the carnivore diet, if you're consuming just tons of cholesterol, yes, your HDL goes up, but so does your LDL, usually to a much, much greater extent than your HDL. And one thing, and this is, we can talk about the carnivore diet if you want to talk about it in this podcast or at a different time. But the problem about the carnivore diet is, you're consuming a huge amount of cholesterol along with a lot of animal fats that are all pro-inflammatory. And what we don't know is based on your different genetics, how that affects your particle dynamics. So, we don't know if yet, because your HDL goes up with a carnivore diet, is all that HDL, is it large HDL particles that are protective, or is it actually increasing the small particle dynamics? We just don't know.
You mentioned the small ones are kind of just redundant. They're not.
Yeah, they don't
they're not
provide-
a negative. They're just sort of a zero.
They're not negative, but they don't provide any benefit. And that's the
Yeah.
whole idea, is when people say, oh my gosh, you've got a great HDL. Well, is it actually protective HDL, or is it non-protective HDL?
Because there's a lot of the problem with a lot of the studies that we're seeing with the correlation of heart disease, health issues, and meat. The problem is usually meat is part of the diet, but it's like lasagnas, burgers, and they therefore, these studies are, because meat's part of this diet, meat is bad, when it's like, well, maybe all the sugars in the buns or all the processed pastries, etc.,
Or the cheese and the
all
lasagna.
the extra stuff, all that extra stuff and like after we did the carnivore month in January, I felt really great short term, but I did have to add some fruit. And I'm still lean more towards more meat, but I do incorporate other things. So I'm not like a dogmatic carnivore person.
Sure.
But I do feel like, and I'd love your input on this, that most of the studies that we see around most correlations of the negative side effects of meat, unfortunately, are very thwarted with kind of biases. And we see that like they compare, like they kind of just lump meat in with the standard American diet, which we all know is terrible.
Yeah, you're a meat eater or you're like a vegetarian, and like, oh, well, the meat eaters have a higher degree of atherosclerosis and heart disease and obesity and so on and so forth. But then these people who know meat, they're like less. But like the meat eaters are eating like shitty quality meats. They're eating them with starches and with inflammatory foods. If they ever could or would, or somebody actually would invest the money to truly get a true hardcore carnivore,
there you go.
Versus somebody's not.
Well, they've done one recently.
But there's no
that Jeff
prolonged.
And I reviewed. Have you had a look at any yourself? Because Jeff and I had a look at one that it wasn't 100%. It was like 90%. And the studies across 12 months, which I know 12 months can be quite a short study, but they were crazy positive. Have you looked at any of them? If so,
Yeah, I mean, not really. So I really couldn't sit there and elucidate as far as like, okay, yeah, there's some studies out there that show that doing carnivore. Now, I mean, when we start talking about, so when people say I'm doing a carnivore diet, they're really doing a ketotic diet because they're eliminating sugars out of their diet, and the body's actually going into ketosis. And of course, if you are a male and you have a huge amount of visceral fat, and all of a sudden you go on the carnivore diet and you lose all that visceral fat, then it's kind of one of these tough things to sit there and say, okay, yeah, we know that there's a lot of LDL cholesterol that you end up developing from the cholesterol you're consuming from animal fats. And then, of course, you have all the inflammatory problems from the animal fats that you're getting. How does that play into somebody who is really obese and then transforms their body by doing that? Where do their risk factors come into? And this is where I'm like, just get the heart scan.
Right. Well, and I think
because we start sitting there talking about this stuff, and it's like, well, how does it work?
And
blah,
some
blah,
people
blah.
genetically can handle that protein.
Well,
and actually, that's what I was going to get to. And that's such a
I had
key
Hershey
point.
Kisses poops when I was on there.
I was just going to actually add to that, like the
I missed a good
predisposition
one, but-
of that person. So
Do you
Yeah.
have any opinions or not opinions, but a knowledge behind foods? We were touching the EPA. Are there foods that help with heart health? Heart health, usually we think of, again, visceral fat, but is there anything in particular that is going to help our heart strength and longevity?
Well, I mean, when we talk about like just heart health, we're talking about reducing atherosclerosis. So, unfortunately, this still comes down to consuming large amounts of fibrous vegetables, because fibrous vegetables, and something that we didn't elucidate on, but fibrous vegetables pull cholesterol out of our gastrointestinal system. So bile, which our livers produce to help assimilate fats and cholesterol, is nothing more than LDL cholesterol. So when you consume fibrous vegetables, it actually binds up bile and pulls it right out of your system. On top of that, obviously, vegetables don't have any cholesterol in them. And the proteins you get from vegetables are also anti-inflammatory.
Proteins?
The proteins. So there is
proteins.
inflammation.
Protein and potato
okay.
protein.
Yeah, so there is different inflammatory, areas as far as protein goes. So they usually sit there and say that, unfortunately, animal protein tends to be pro-inflammatory. Fish protein is neutral. I mean, is not inflammatory or it's not anti-inflammatory. And plant protein, of course, is anti-inflammatory. And of course, all the vegans are jumping up and down when I'm saying this, but I'm like, there is huge benefits from consuming fibrous vegetables, but some people can't do it. I have IBS. I look at broccoli and I look like I'm 9 months pregnant. So some people just can't consume it.
Unfortunately, vegetables of today are not the vegetables of yesterday. How they're grown,
The way they're correct,
all the
mass,
different toxins, mass farming. If you look at what corn should be versus what it is, or you look at what a carrot should be versus what it is, these GMO versions, these ones are sprayed with all sorts of glyphosate, or they're mass farmed. The quality of the vegetables sucks. And this is where I started changing my dietary habits a lot, because I don't trust seafood, because I think, look at the microplastics and the quality of what's
Heavy
in the water.
metals
I really have a hard time with a lot of vegetables and grains because I know they can't be farmed in a way that's economical to most farming industries.
Even organic is
So
questionable.
then I look
now.
at these, meat products. I'm thinking, well, chickens are kind of dirty bird and they eat a bunch of shit. So I don't really know where they come from.
I don't trust chickens.
So you look at beef and you look at these animals that have the 3-chamber stomachs and you're like, well, okay, that kind of starts to make the most sense, because this animal, this cow has 3 opportunities to kind of filter the food best. And now if I buy good quality and I buy, the grass-fed, grass-finished versions, and I stay more in line with the organics, am I making the right path and choice for myself, and then we go back to the carnivore diet and then the keto diet and all these different things. If it prevents me from getting visceral fat, which we already know is a very major health issue, and my insulin levels are low, so I don't have inflammation due to high blood glucose values, now I'm thinking, well, shit, I'm on the right path. Now I know your answer is go get the scan.
Correct.
See, but I can only do a scan every 5 years. So now if I'm doing a carnivore diet in the middle of that 5-year stint, am I like, fuck, man, I made a mistake like 3 years into this when I go back up to my numbers
Can we
100.
use the F word here?
Yeah.
Okay, you do whatever you want.
Yeah.
But I mean, listen, man.
we filter those out.
But it looks like
I'm
you're
terrible at it.
But anyways, yeah. I mean, to your point, so and again, yeah, you want to know what your genetics are. I mean, if you're a guy and you're like, man, I want to go on this carnivore diet. I've heard a lot about it. Everybody's talking about it. You actually have physicians that are
Paul
promoting it.
Saladino, some of these other big name guys,
Which I think is atrocious, but I mean, that's something
Bit of
a
a
different
grifter.
aside. But my whole point to them is that's great. If you want to try it, go get the heart scan done first. See where you're at genetically based on atherosclerosis. If your arteries are clean and you want to lose a bunch of visceral fat, knock yourself out. But then recheck your heart scan again, in maybe less than 5 years, a couple of years, if you're staying on the carnivore diet to make sure you're not actually developing atherosclerosis. People blindly think that, oh my gosh, this diet is great for this person. Well, it's got to be great for me too. I'm like, we're all different.
Well, and I think
this whole idea that we're all lumped into one cube, that we're euboxic, that everybody's the same is insanity. And what diet is good for one person is going to be harmful potentially to somebody else. So you can't sit there, and I can't stand when physicians go on there and promote the carnivore diet because people go, well, this guy's a doctor. If he thinks that he's doing it, it must be totally safe. And that could kill that patient.
Well, Paul Saladino is not even a carnivore anymore.
Okay.
So yeah,
But
that's why his carnivore MD handle changed. But
yeah, my philosophy on most of this stuff is, and I think is a lot of the way a lot of people live life nowadays, is what's the lesser of two evils. It's not so much what's the most healthy or the best for me. It's almost like you're damned if you do or you're damned if you do.
Well, you're damned no matter what. You're dying.
You're
no
damned.
matter
You're
what.
dying. So you're on a path.
We're all gonna
You're
end
on a
up
path.
dead.
100%
right? So if I can
cardio-
choose
100% mortality.
if I can choose a diet that makes me put on less fat and have lower insulin issues, but then again, it's potentially building a more plaque. And I know you're going to say, well, that's the number one, killer in America. But then this other one, diabetes, is so. I feel people have to pick up. We don't suggest diet to people. We choose to do what
Options.
we do. I know you kind of preach to people when you
Well, I
talk
teach a
about
balance.
what's their most healthy choice.
I don't say no meat. I say make sure you're balancing things out. And of course, if you are like a heavy atherosclerotic patient, and you've got your heart scan done at age 50 and your score is off the chart, you probably should not be eating meat on a regular basis. It should be, hey, on my birthday I'll have a steak or whatever. You should be trying to eat as clean as possible.
Steak cake.
But we can sit there and talk all day long about this stuff. I mean, when it comes down to it, quality of life is still more important than quantity, at least in my mind. And I've had patients that are like, Doc, I love steak. I'm like, knock yourself out then.
Yeah.
If that gives you quality of life where you're like, this means everything to me, I'd rather die at 75 with a steak in my mouth.
But we all say that until that day at 75.
Well, but that's it.
Like,
I mean,
shit,
I always have to sit there and I have to advise patients. And of course, everything's informed consent. When anybody does anything, you want to make sure they understand all the potential risks and benefits of whatever they're going into, and a lot of times that's just not given to patients. They sit there and of course they go on the internet and you can get any information you want to, and there's no informed consent on the internet.
Yeah.
I mean, people will sit there and promote this, promote that, and great. That sounds wonderful.
Hey guys, so just quickly, we've noticed a lot of you commenting that you're not sure where you can go to get trusted and safe peptides, semaglutide, tirzepatide, testosterone replacement therapy, or testosterone boosting therapy. And we wanted to just make mention that T Clinics USA is one of those places. Now, Alex and Jeff, who you see in this podcast frequently, they're probably in this podcast right now with me, they are from T Clinics USA. And as they've shown in episode after episode, details is what matters. So just because you may want something or think you need something, they are going to make sure that you are getting the thing that is right for the goal that you have. And what's better is they offer a 10% introduction discount to anyone who is listening to the ManLab. So that is you. So if you wanted to make use of that, get peptides or testosterone from a place that you can trust that have your goals in mind and want to show you the right way to get there, go to tclinicsusa.com, mention the ManLab for 10% off your first package, and you can even ask Alex or Jeff directly any questions you may or may not have, which is kind of cool. So just again, tclinicsusa.com. If you don't want to remember that, the link is in the description of wherever you are listening or watching this podcast. Mention the ManLab in the contact form and you will receive 10% off your first package. Now let's get back to the show. Quickly, before we get back to the episode, please hit that subscribe button if you haven't on whatever channel you're watching or listening to the ManLab. And if you're listening on Spotify, if you could leave a 5-star review on the channel page, that would be greatly appreciated because that will help continue to push it a little bit further for whoever is looking for information to help improve their health. Now, on the topic of information, if you are on YouTube, you can leave a comment below on this episode and we will respond to it with as much information as possible, or it might be another episode down the road. The reason this is important is because the more questions you guys ask, the more we know what we need to do to serve you guys better in future episodes. So comment on YouTube, leave a 5-star review, hit subscribe, and let's continue to help making men great again. Let's get back to the show.
Speaking of that, so there is a big focus at the moment on seed oils. They say it's highly inflammatory. It feels like it was carnivore last year, and now all of a sudden seed oils is the big concern or focus
I don't need
point.
any seed oils.
Is it as bad as we make it out to be, or is it overkill, or is it actually something we should be
It's
mindful of?
polysaturated, polyunsaturated.
Yeah, so they could be more
mono.
pro-inflammatory. I mean, still, if you're going to consume oil, the best is still, extra virgin
Gasoline?
olive oil.
Oh,
Yeah,
sorry.
gasoline.
He's gonna go
That'll fix all your problems, whatever they were.
He's gonna say disclaimer: check your predisposition first.
Well, let's
So
let's-
But
let's-
olive oil is still.
Olive oil is the one seed oil that people it's fine, but everything
Correct.
else is.
Well, I mean,
avoid.
there's kind of like grades. So it's like olive oil is number one. Number two would be like macadamia nut oil. Number
oil.
three would be like a really pure canola oil.
canola oil.
Canola
But if
oil.
you have like a really pure organic, I mean, like the regular canola oil you get is crap.
What about avocado?
Avocado? Yeah, that's
Coconut
another
oil.
one.
Coconut oil.
Coconut oil.
MCT.
And with those, do we avoid cooking them? If you heat them up, they become rancid, or is there like
Olive oil, yeah. If you, supposedly if you really get the olive oil super hot, it can. You can actually start breaking down some of the anti-inflammatory nutraceuticals. The one thing in olive oil is called something called hydroxytyrosine, which is a really potent anti-inflammatory. Coconut oil is great to cook with because
Has a
it
high
doesn't
burn
break
rate,
down.
too.
It's got a very, very high flash rate, temperature, loaded with MCTs. Now, just because it's got MCTs, which stands for medium chain triglycerides, which ideally your body would rather burn those as energy than store them as fat, doesn't mean that if you do nothing but
Abundance,
coconut oil,
right.
you're going to be super lean and healthy. No, you're going to get fat. I'm just telling you.
Still calories.
So you're right.
Still
Everybody sees MCTs like, oh, this is great for me. I'll just consume
Well,
all the MCTs.
we promote it when in a keto diet and looking
Correct.
for
Now,
energy
in a
before the
keto
gym or
diet,
something like that.
100%, because keto is a fat-based diet. So that's all you're consuming are fats. And so obviously if you're doing keto, then yeah, you want to incorporate a lot of MCTs in your diet. But I always try to tell patients, listen, keto does not mean bacon, pork, and steak. You can definitely get keto with avocado, olive oils, nuts, which are super healthy fats, which are anti-inflammatory. Yeah, throw a steak in there. There's nothing wrong with that if you're doing keto and you're trying to be as healthy as possible. But this whole idea that literally you're doing nothing but bacon fat, I'm like, I mean,
that's the way of the world, making the
well,
plan fit
and
what
then
they want.
let's just
If it
say,
fits in macros.
happenstance that your body is super resistant to atherosclerosis. You have resistant arteries. You have resistant lipid numbers. That does not correlate with anti-cancer. So the two major causes of death, cancer and heart disease. And what's interesting is cancer is catching up to heart disease. And you want to know why? Obesity.
Right.
One of the biggest problems we're dealing with.
So that's
is one-
causing more cancer than it is heart disease.
I'm sorry.
Well, because
So-
sugar in the bloodstream is
Diabetes
where cancer
mellitus.
I
Sugar
would not
is
have
so
guessed that.
inflammatory, so super
So
inflammatory.
and I do want to touch. I know we're going to kind of jump over this, but getting into the semaglutide tirzepatides
Yep.
because we do want
Yep.
to chat on that,
Absolutely.
and how that goes well beyond
Hugely
weight loss.
beneficial.
Well beyond weight loss, and I guess now's as good of a time to pivot as any, because I do want to speak on hormone replacement and kind of your position
Sure.
on that, the use of peptides, but. These new GLP-1 drugs, semaglutide tirzepatide, we prescribe them. Obviously, we use them for weight loss purposes. As a cardiologist, as a doctor who believes in kind of general health and longevity and all these different things that we really preach as a kind of wellness-based, offices here, what is your position on these drugs and their impact on cancer and heart disease and these other prevention aspects that they're starting to discover that they're going to offer well beyond weight loss?
Yeah. So, I mean, absolutely. If you cannot lose weight on your own and you end up using a GLP-1 agonist, there is 100% proven heart benefit that it lowers your risk of heart disease and likely lowers your risk of cancers because of allowing you to reduce your weight. But it has, these other benefits that we always talk about. Now, does that mean that everybody should be going on them? No, obviously. We still want to sit there and make patients understand that we still try to get people to eat as healthy as we can. We don't want people sitting there turning to a drug to sit there and solve all their problems. But they are extraordinarily beneficial for helping patients to maintain.
But what about using it prophylactically? Like, what about using a low dose just to regulate your blood sugar and to help
and
avoid
see, unfortunately,
those
I can't even.
Well, I'm not
yeah.
saying prescribe it, or even recommend it, but what is your thought about people who are doing that? Can you see the validity?
I mean,
of,
but I mean, again, you got to understand that unfortunately, me being an MD, I can't sit there and say, "Oh, yeah, that's great. People should be doing this." I can't support that without them having some sort of study showing that it's safe using low dose GLP-1 agonist long term, and it's going to have a mortality lowering.
But
benefit.
by concept,
because
absolutely. You're lowering blood sugar.
Absolutely,
in
by
my
concept,
mind, as a guy who knows enough to have some level of conversation, I see sugar as being the thing that causes so many problems. I mean, they call it's type 3 diabetes is Alzheimer's, right? Mm-hmm. And so you're thinking, well, high sugar levels is creating brain cognitive decline. That inflammatory markers, just in simple like your joints hurting and stuff, when you go on these medications, all of a sudden your body feels better. And I can imagine the same inflammatory kind of reduction is affecting my heart positively, because those same conversations we've had for the past half hour about inflammation in the arteries has to then be there, to some degree reduced too. So I think like the future of these medications and what we're going to find about the discovery with more and more studies is going to be pretty profound.
Yeah, I mean, I agree with you. I mean, obviously, it'd be great if they went out and actually did a study so we could sit there and say, hey, listen, we're promoting this because we 100% know that it works. And it's always hard, when we start getting into some of these medications that we're like, wow, they have such great benefits. Everybody should be doing these things. I mean, this is the folly, because I remember when statin drugs came out, everybody should be doing statin drugs, and that's just not right. Now, I don't think, obviously, that GLP-1 agonists or anything like statin drugs, they actually have a profound benefit. I just can't sit there and tell, the listening population that, oh, yeah, everybody should be going on low dose. I mean, I think, theoretically, it makes sense.
Kind of like metformin they've did for so many years.
Metformin,
for so many years to get blood sugar down, keep the pancreas working good.
All these different like drugs are used for different
but blood
purposes of
sugar is
longevity.
the most inflammatory substance in our body.
Mm-hmm.
I mean,
and that's why you feel great when you're on a keto diet. Like
correct. I mean, this is why we actually utilize prolotherapy. Prolotherapy is nothing more than sugar water. We inject it into joints.
Inflammation.
Yep, to create inflammation, so that actually you attract all these stem cells, fibroblasts, scar tissue cells to go in there and heal the area. That's how inflammatory blood sugar is. And so when people sit there and say, oh, my blood sugar is a little high, I'm not worried about it, I'm like going, well, you should be. When we talk about like A1C, and A1C is a marker of how we follow diabetics, and a A1C, less than 5.7 is considered to be normal. Well, diabetics usually run 6 to 7. They say, oh, as long as you're under 7, you're fine. I'm like, well, as long as you're under 7 is way better than being above 7, but it's still bad.
So
Any blood sugar, unfortunately, as blood sugar goes up, so people think, oh, my A1C is close to 7, it's 8. I'm like, do you know that's twice as bad as 7, and 9 is 4 times as bad as 7, and 10 is 8 times as bad. It's like it goes up exponentially as far as the amount of damage that's occurring. So people walking around with a A1C of 10, like, nah, I'm doing okay. Like, no, you're not. I mean, this is why your
Your foot's
arteries
about
are
to
just
fall off.
Yeah, I mean, their arteries are shredded. Their kidneys are damaged.
They don't
damage their
realize
brain,
their
their
body's
eyes.
having damage because of this.
Yeah, they have no idea. But blood sugar is so inflammatory. So to Alex's point, this is why it's important to sit there and quit doing all the damn sugar. If you're going to do carbs, they should be very complex, low glycemic index carbohydrates. This is the idea behind keto. And again, obviously I'm a big fan of doing healthy keto. If you want to throw, like I said, some steak in there every once in a while, fine. But try to stick to, fatty fish. Sardines, amazing. As our commentator vomits.
Blake would just starve to death.
I'll take the
forget
death.
it. But salmon's also outstanding. A good fatty fish, which you can use for keto. And then, you can stick with doing, your
You typically
nuts.
recommend more of a Mediterranean diet. don't
We
you?
do. But I mean, they've actually shown that the primary benefit of the Mediterranean diet is actually the olive oil.
Right.
So more olive
drink
oil.
it.
Well, and you're
Just
relatively
drink the
lower
olive oil.
carbohydrates.
All right,
I
so
mean,
on to
What
Well,
about-
again,
just
correct. They're
quickly,
using a lot of low glycemic index
artificial
carbs.
sweeteners then.
Horrible for you.
Okay.
Absolutely.
but are they
So-
better than sugar? Like if you're going to have a coffee and you want it sweetened,
stevia. If you're
oh,
gonna
it's
do
so bitter, it's disgusting.
I know, but the problem is that
So what's the reason that they're horrible? Just quickly, that's
well, I mean,
point.
not only like Splenda, actually, it can be consumed by your gut bacteria and it kills them. So you can actually disrupt your entire biome.
Man, I just had a
with
C4
Splenda.
this morning.
There is concern that Splenda, especially aspartame, can cause cognitive decline, early Alzheimer's.
You're
type
eating a lot
dementia.
of it too. Like if
If
you
you're
have
eating a
like
lot
one
of it,
coffee,
but
a
I
day
mean,
with
I
it,
tell
you're like-
I tell patients, listen, I mean, okay, what's worse, eating a pound of sugar or doing artificial sweeteners? They're probably about equal, honestly. They both cause harm. I would sit there and say, if you have a choice, just eat less sugar. I'd prefer people not to use artificial sweeteners, unless it's going to be stevia. And I understand stevia is not
Monk
the
fruit's
best
not
tasting.
bad.
Monk fruit, exactly.
What
Monk
about
fruit's
if
also
you're
fine.
a very active person? So myself as an example, I've been trying to take like the C4s, the sugar-free Red Bulls to minimize the sugar intake. However, if it's a cognitive decline is an issue from those artificial sweeteners, would me having the sugar version of that be okay considering my energy output is extremely high? Or because the reality is I've tried coffee, I just can't do it. It doesn't. I actually feel bad after coffee.
Oh, really? Okay.
But this is the problem is I know that logically and scientifically coffee is better for me than energy drink. I feel bad after coffee. I feel good after an energy drink. And everything in me wants to say, you're an idiot. But it's like, I'm pretty...
Try green tea.
It doesn't hit me enough.
Yeah.
So in the case of someone who has a high energy output, like I go to the gym every single day, would having that sugar be a problem, or like would you still
And I would tell
recommend
you,
avoiding
someone
it?
like you, specifically you, because you've got a high
This is a
metabolism.
selfish question.
Correct. Well, no, correct. You've got a high metabolism. You're fit and lean. Extra sugar is not going to hurt you because you're not diabetic either. So, I mean, literally, people that are not diabetic, if they were to sit there and consume, a relatively controlled sugar diet, and you were to check their blood glucose or their A1C, it's going to be low. So, I mean, excess sugar absolutely can lead to obesity. But if you are staying super fit and you're exercising regularly, the sugar is not harmful to you as opposed to like consuming artificial sweeteners. But if you're overweight, God forbid you've got borderline type 2 diabetes. Sugar, I mean, it really comes a tough question. And then I'd probably tell you to do an artificial sweetener as opposed to sugar because
the obesity
of
is more of a problem.
Correct.
Yeah.
The risk is so much higher for you because you're diabetes. But that's why I can't stand this whole idea that medicine's everything with a big paintbrush.
Right.
Like
No,
everybody's
yeah.
equal. No, everybody's individual. And so you sit there and you tell each individual person, okay, you're fine to have sugar, a little bit for you and 0 for you.
Yeah.
So it's all individual. And this is why it's so important that each person be analyzed separately. This is what we do at the clinic. We take each person individually and we analyze them and decide what is the optimal therapy for you,
Right.
not for the population, but
Don't
for
do what
you.
I do, but
Correct.
That's
Well,
the
no, you
tricky
can't
thing
blanket
is-
it.
I'm trying. Well, that's the tricky thing is like I'm trying to always like I'm trying to think 10 years ahead, but even that.
Well,
10
you
years
should. I wish everybody did that.
Yeah,
But at the same time, you're not the
but I'm
person
still
you're
not
going to be
sure.
10 years from now. So right
That's-
now, you're a thin, lean,
But-
athletic guy.
well, that's
you can
true.
burn that sugar.
But I mean,
that
like
10-year-old
prevention. What am I doing
future
today?
You may not be capable
And
of.
if your body metabolism physique changes, you have to
And
adapt.
adjust.
And that's why it's this whole thing of going, well, I was eating sugar fine for 20 years.
Yeah.
Now what's going on? It's
You
like, well,
weren't.
you can't eat sugar now.
Or you don't
Yeah.
move as much.
Or you don't
your
move as
job's
much. So
different, you're on
you
your
have
feet.
to adapt as you age. And this is the whole thing about the aging process is that you have to work harder and harder, be more aggressive about your health the older you get, because your body is actually going through a lot of transitions. And if you don't start adapting to those and changing what you're doing,
Yeah.
you're going to end up dying earlier or having a poor quality of life, which I think is more important than absolute longevity. We always talk about, longevity, and it's like, okay, that's great to a point, but if you're 95 and you're in a nursing home and you're miserable, it's like, I would have eaten more steak at that point.
Yeah, I would have happily died. Because
Yeah.
that's the thing. Like, I've had 3 major pivots in terms of how I eat, and that was 24 years old, 28, and 33. I was just like, okay, big adjustments.
And you'll continue to change
And
that.
I will. Like,
I mean,
and that's
so-
what I mean. Like, it's such a tricky situation though, because I'm like, all right, minimize the sugar, because sugar, it's type 3 diabetes is Alzheimer's. So I'm like, all right, cut that out. But then the alternative is still a cognitive issue. So I'm just like, what
Do I want
do?
type 3, type 2?
I know.
Which
I'm
one?
just like sort of picking my poison.
in the spirit of the time here, so I do have a few things I definitely want to
Sure.
make sure we touch on.
Yeah.
Testosterone replacement.
Yep.
So, as you know, obviously our business, T Clinics, and we've been always in the business of
Sure.
hormone replacement,
Absolutely.
testosterone replacement,
Yep.
men and women. When going on testosterone replacement as a man, right? So one of the things that we measure is blood test numbers to determine whether you're taking enough or too little.
Correct.
We go off of this kind of like scale that is determined as the range, the low range, the high range. And we know those ranges have changed over the years. As a doctor, and I know not the prescribing doctor, but as a doctor generally, what is the risk in your testosterone levels being too high? So guys are always wondering, like, my level's 1,500. It's just a number. So then what I say to them is, okay, if we're looking at this number, do you have thick blood? Do you have an elevated PSA? Do you have high aromatase in your estradiol levels? Are those the only problems that come with this potentially high testosterone, or is there other things that we should be aware of? And if not, let's talk about those 3 risk factors and what that potentially can lead to.
Yeah. So, I mean, they don't have any great studies looking at people using like excess testosterone. So, and one thing to your point, people always talk about, testosterone numbers like my testosterone is 1,000, my testosterone is 900. That's actually the total testosterone. And one thing we always focus on, Alex and I, is what is the free testosterone? The free testosterone is a direct testosterone measurement, which is the amount of testosterone available to the body to utilization. And that's one thing we always actually look at because that's the most important number. But, excess testosterone, the major risk, number one, is your prostate. And there is a definite correlation, unfortunately, between higher testosterone levels and prostate cancer. So they did this novel study. This is not patients that were on testosterone replacement. These are on patients that just had naturally high testosterone levels. They unfortunately had a higher rate of prostate cancer. Now, does that mean if you do testosterone therapy, you're getting prostate cancer? Absolutely not.
But aren't all men eventually going to have cancerous
And this is
cells in your
actually one
prostate
thing that's
no matter
interesting
what?
is, yep. So
And
if
isn't
you,
testosterone relatively prostate protective as well if you stay high throughout your course of your life?
yeah, I mean, that's kind of a tough call because we don't really know. We definitely know that most men, as you age, will develop prostate cancer. And most of the time, it's not anything that's clinically significant, never causes any problems. You were to sit there and analyze.
Because the prostate's encapsulated. It's
Encapsulated, but I mean, obviously, prostate cancer is still a major problem, in this country. And this is why we're so aggressive about testing PSAs on a regular basis, because we want to catch prostate cancer. And, so there's some components to, the prostate and hormones. So what's interesting is actually high estrogen levels are actually one of the major implications of initiating prostate cancer. People think it's always testosterone, but it's actually estrogen. And this is why we always focus on making sure your estrogen level is controlled, because that can actually initiate prostate cancer. And then it's actually dihydrotestosterone, or DHT, that actually really activates those cancer cells and makes them grow. Testosterone itself, when it's not DHT, actually is somewhat prostate protective. It actually does have lots of benefits for the prostate. It's unfortunately DHT, which causes all the bad things we think about. Now, you need DHT. If you had no DHT, people are like, well, get rid of DHT then. I'm like, well, then you wouldn't be able to get an erection.
Right.
You wouldn't care about sex. I mean, kind
That's
of
all
an
the good
important
things
thing
of
for men.
You'd be depressed.
I must be low in
Depressed,
protein.
emotionally, yeah.
You'd have-
So you have to have proper ratios, and that's one thing I always look at in this clinic is we always try to make sure that we're controlling estrogen levels, and if patients are clinically having any signs of excess DHT, we make sure we go in there and control DHT.
Which is, again, there's a lot of moving parts to this question. I think we're going to kind of go back and forth for a moment, but I hear from a lot of people coming from other practitioners and or have become, YouTube experts. They're like anti-aromatase inhibitor. Like, oh, that shit is terrible. And I'm like, you know what's even worse? High estrogen levels.
Absolutely.
I don't care all the things you say inostrozole may create or cause. If you can mitigate your prostate cancer potential risk, if you can mitigate gynecomastia, putting on high blood pressure issues that come from elevated estradiol, what's your tone on? And I know you kind of
He's cardiology. That's like
you actually are a little bit more liberal in your prescribing of aromatase inhibitors, comparably to a lot of practitioners. You believe in prescribing them quite
Absolutely.
often.
You want to maintain
and
those
pretty high
ratios.
dose. So, is there too much anti-estrogen use, do you think, or do you feel people should almost take more of it in order to be preventative?
Yeah. So, good question. Men actually do need some estrogen for maintaining a normal sexual health. So just like women need some testosterone, men need some estrogen. So there's a proper ratio.
So like zero testosterone, you're like what?
Or no, zero estrogen. Zero estrogen can actually lead to the same sort of problems as zero DHT. People actually will also have a problem like maintaining an erection if they have zero estrogen. This is actually seen more as you age. Now, obviously, when you're young, it's not a problem. But this whole idea that, aromatase inhibitors are bad, I'm like, excess use of aromatase inhibitors, might cause problems, liver problems, things like that. But we've never seen it in the doses that we actually utilize. And we're always, obviously maintaining appropriate ratios of testosterone to estrogen. And each individual person is different. Again, some guys produce a ton of estrogen because they have a high aromatase activity. And if you were to sit there and say, oh, well, all aromatase inhibitors are bad, and you let this guy walk around with massively high estrogen levels, he's going to have a really poor experience with testosterone replacement.
Because very little of that total testosterone finds its way to the receptor site to become
estrogen
free
is kicking
testosterone.
off the testosterone.
Get the hell out of my receptor site's way.
Yep. So people don't realize this.
It's a typical woman, right? It's like I want to be here. You get out of here.
Yep. So your receptor sites
It's
in
the
your
boss.
body respond to both testosterone and estrogen. And so if you have a very high estrogen level because of a high aromatase activity, it's actually displacing testosterone from those receptor sites. And this is why people get gynecomastia, is because of excess estrogen. Also, you primarily see this in men that have been doing testosterone, and then they have been doing a aromatase inhibitor, and they quit doing testosterone for whatever reason. Estrogen takes a long time to metabolize, where testosterone metabolizes very rapidly. And then you have nothing but estrogen circulating around, and then you definitely grow breasts.
Well, isn't it true being cardiology that, over suppressing or keeping estradiol chronically low could decrease HDL? Which increase your chance for plaque deposition in the arteries.
Yeah, and this is why you see, especially a lot of the pro bodybuilders that are using heavy anabolics, they have very, very low estrogen levels.
Or like letrozole and all those.
Correct.
It's overshooting.
Overkill.
Yep.
And their HDLs are very low, and they have a very much higher rate of atherosclerosis.
So again, the takeaway is don't be scared of aromatase inhibitors.
Correct. No,
they're actually
absolutely
more
not.
protective than the potential risk of maybe joints being dry or shutting down your
And
sex drive.
there's got to be a balance.
The balance
Absolutely,
of
100%.
enough. Now, what about the polycythemia issue? Because we preach all the time, guys. Like if you're gonna pay, you have to play, right? Part of the paying with testosterone is that you gotta keep your blood levels within a manageable zone. But then there's this idea, of course, people know like Lance Armstrong and some of these athletes intentionally create higher density blood. And they're thinking, well, why is that athlete intentionally making their blood thick to carry more oxygen? Doesn't it make me more athletic? Why are you telling me to dump this blood that's like so valuable and has all these anabolic and aerobic benefits? So what is the risk of having polycythemia, which is the elevated hemoglobin hematocrit? Why do we recommend getting it? And ultimately, why does it happen? What is
great question. So, and again, this is, individual genetics. Not all men develop polycythemia from doing testosterone. I'd probably say you're fortunate. I actually developed polycythemia from it. So generally about 70% of men, if you give them enough testosterone, they'll develop polycythemia. So the androgenic part of testosterone, which androgen means male creating or male activation. So androgenic properties activate all the male type qualities. It also ends up increasing the turnover in production of red blood cells from the bone marrow. So you increase production of red blood cells. And to his point, exactly, there's actually something called blood doping. It's illegal in the Olympics. And just a really quick aside, what blood doping is where athletes will sit there and remove a pint of blood from their body, they'll store it, and then they'll reinfuse it 2 days prior to the event.
Usually go up to high altitude,
so
Colorado.
Correct. Or you can also do it by living in the high altitudes.
I used to do that. That is
But
rough.
you artificially increase your red blood cell capacity, which increases your oxygen carrying capacity. And absolutely, you have a higher oxygen carrying capacity, you have better endurance and better energy levels and better aerobic capacity, better metabolism. But that's up to a point. So red blood cells, they are actually cells, and they actually add to the viscosity of blood. And so no different than like your engine. If you put a super high viscous oil in your engine has a hard time moving that oil and keeping it running. Same thing happens with polycythemia. You get excess red blood cells, and this is typically when your hemoglobin gets above a level of really 18. 18 is really kind of the max. After that, the blood starts increasing in thickness, where it's harder for your body to move it around. And the unfortunate reality of blood, or fortunate depending on your circumstances, when blood is not moving properly, it does what it's supposed to do, and that's clot. And so the last thing you want having to happen in your body is your blood clotting inside of your body when it's not supposed to be. Obviously, if you get a cut, you want your blood to clot, but you don't want your blood to clot in your leg, like in your leg vein. So the venous system of our body is a slow-moving system. The arteries are pumping blood that is being forced by the heart. So it's a very, very high-flow system. The venous system, very slow, blood's moving sluggishly. And if you have a hemoglobin greater than 18, your risk of developing a clot in one of the veins in your leg starts going up. Some people are actually more prone to this if they have higher clotting factors in their body. But they will have a much higher chance of getting a blood clot in their leg, which then could end up resulting in a blood clot going to their lungs, called a pulmonary embolus, which could be fatal. So not every man that does testosterone, and of course not every guy that does even max normal testosterone. And so we talk about what is max normal. Max normal is what is actually allowed by the DEA, the Drug Enforcement Agency, because testosterone is a controlled substance. We have to monitor our levels to make sure that we're maintaining compliance. But the max normal for men is a free testosterone of 30. Just about every guy that gets a free testosterone is 30 is probably going to get some level of polycythemia. Not everybody will, but the majority will.
But on that note, real quick, we were talking about this 30 number. We use a day of the week of the injection cycle to determine this, and oftentimes it's at the lowest point of the week. Because how else and where else do you measure? If I took a shot on Monday and I check my blood work on Tuesday, well, that free level is going to be significantly higher. So then, with that kind of concept of over 30, you're talking about having this polycythemia risk. That means almost every man on any sort of testosterone therapy, I don't care if you're on small daily microdosing or you're taking one shot a week of 200 milligrams, at some point in your week you are excess of these free levels. So that means that almost 100% of the men on therapy have an exaggerated risk of polycythemia, aside from people like myself who are genetically safe from it, if you will. But we tell these guys, you go do your blood work, go do your blood dumps quarterly. And they're always kind of feeling like we're just being a pain in the ass because we want to see on their blood work it come down. But the true risk is you're going to get a blood clot. And if you get this blood clot, you can have a stroke or you can have a heart attack. So it's not we're trying to be a pain in the ass. We're not just trying to see blood numbers on a piece of paper look okay. We're trying to essentially save their lives, right?
Yeah, and one thing when I do consultations with patients, and they may forget this, but I always tell patients, I always forget this stuff. I always tell them the importance of actually doing blood donations to control their polycythemia, but it's actually a win-win for society because we need blood actively, especially the O positive and negative patients. It is super important for those people to go get blood regardless. But, if you're on testosterone and you're actually developing polycythemia, give us your blood, please. We really need it. So it's not a bad thing. It's a win-win for society. It's a win-win for you.
On that note, is it regular blood or double red? What's the difference between?
Well, double red is you're giving the plasma back, but you're actually removing 2 units. Yeah.
So does that lower my level even more?
Well, it does. Yeah, and they'll do double reds on patients. That as long as they haven't been given blood, within the past month, they can do it.
60 days is 58 days.
But double red to actually remove is double the amount. But they're giving your plasma. Yeah, they're giving your plasma back so they don't remove too much volume from you.
Okay.
But that can really lower, especially for patients that come in and they haven't been responsible and they get their blood checked and all of a sudden hemoglobin's 19. We're like, you need to go get a double red.
And then it's hard for them to get it down. And I tell people,
it's a little difficult,
once it's high, you're fighting an uphill battle to get it down into range. Once it's in range, it's easy to keep there. It's like 3 times the work to get it from a 19 to a 17 than it is to keep it from a 17 to go into from 17 to 16. It's easy because these red blood cells almost kind of create more of themselves and kind of create a density that's almost more difficult to manage.
And then you have not just testosterone. So you got someone who's overweight, somebody has COPD, somebody who has
but also increasing
that's going at the same time. So sometimes they can't donate fast enough, but a lot of that could be adjusted with their dosing per that person to mitigate the polycythemia.
The overintroduction.
I mean, you can. And this one thing we'll talk to some patients about, especially ones that are like, listen, doc, I'm tired of going to get blood, every 3 months. I'm like, well, your only other option then is to actually decrease your testosterone level. Right. And then we have that that candid talk and say, listen, if you're running max normal, let's start bringing that level down. Instead of running at a free level of 30, let's bring it down to 25. Over a slow period of time, you're really not going to notice much of a difference. Right. But I mean, obviously, a lot of men that come to our clinic and they're always given the option because we're not going to sit there and tell them they can't do it. But we try to give them an idea about what ranges you can get on testosterone at and how you're going to feel in those certain ranges. Of course, the first thing they ask is, well, if a little is good and a lot better, I'm like, well, up to a point, but we can't go beyond a certain point. So a lot of candidates that come here, they're like, I want to do max normal. Well, I'm like, okay, well, you do max normal, you got to understand that you're increasing your chance for polycythemia, you're going to have to give blood more frequently, and you're potentially increasing your risk for prostate problems. So
the sad part about that range is that range is just the general average of the sick population of men that exists in 2024. Right. We've talked about this in our shows back in the 1950s. That range would have gone up to 1,400 because men were more manly then and didn't have so much obesity and we didn't have so much femininity, right? And then there's different labs, Quest versus LabCorp versus Access. We're working with a new lab company that works a lot more so with hormone replacement, clientele. Mm-hmm. Their upper level of normal is higher because the population of people they see is generally higher. And so that's where I was kind of wondering about, is there a true dangerous zone of being on testosterone besides those polycythemia, estradiol issues,
I mean, not really. No,
all of a sudden, just because I'm taking more testosterone, I'm at danger. If my liver enzymes are fine and my kidneys flowing good and I don't have prostate problems and my blood's staying, relatively within a normal range, does taking extra testosterone create a higher degree of some kind of fatal thing that I'm going to potentially get to?
So they actually did this landmark study. Which we were actually kind of surprised at the results. It was just actually on testosterone replacement therapy to determine does it increase cardiovascular risk? Because people always sit there and think, oh man, if I'm doing testosterone, I'm amping myself up and I got all these levels going on, I got a little polycythemia and everything, is it going to cause heart disease? Because there's always this, suspicion, at least even from the cardiology side, that too much testosterone, even testosterone in general, is bad for you. So they came out and showed absolutely no harm at all.
And meanwhile, it's so villainized.
So if you have testosterone at a level 1,500, 1,600, not a concern.
Now again, those are total levels. Yeah. Now we're talking about, as long as your free level is not over 30. But 30 is the max free level,
But that's just because the DEA deemed it to be the highest level.
But we still can't go beyond that. But we've actually had patients walking around with a 1,500 total and a free level of like 28, 27.
Well, that's also SHBG, albumin.
Well, correct. But still
also.
the point is that, this whole idea that, your total level can't be over 1,000. I'm like, no, that's a bunch of BS, because we got plenty of people that actually need a total level of 1,500 because of what he was talking about, the sex hormone binding globulin that actually binds up our testosterone. Some people just produce a lot of this stuff. And, there's not really a way to get it down. Growth hormone does help with reducing it. But
Uncut Ali.
Yeah, that's
it's amazing though how many yin yang doctors exist out there that people bring their blood test to us and say, I don't feel as good, or something's going wrong, or this guy doesn't know what he's talking about. I'm like, send me your labs. And all I see is testosterone total.
That's it.
Yeah, no correct. SHBG, no albumin,
no free testosterone.
Like, how the fuck are these
and
people diagnosed?
Level.
Like, what the fuck? What is this person doing? They're checking your total. They check your H&H. They check your PSA. There's a place here, a very popular place that's. Yeah. If you're going
starts
there,
with the
it's
C.
too bad for you. You get a shot every 2 weeks there.
Yeah. H.
Like, I see their blood work and I'm like, this is such a disaster. This is
correct. It is.
Well,
and they're actually doing their clients a disservice.
And
one of my, and I have plenty of patients in my cardiology practice that they go to their regular doctor or whatever, and their doctor will prescribe them testosterone. And my first question is, does he do testosterone himself? And they're like, well, I don't think so. I'm like, well,
or the
honestly, in my mind, no male physician has any business prescribing testosterone unless he's actually taking it himself. So he not only understands not only the didactic portion of testosterone therapy, he knows how it feels and understands what it's like to actually do testosterone. So a lot of these clients that come to us, nothing against women, female physicians, but sometimes they have female doctors that are prescribing testosterone. They're going by the book about what it says. And a lot of times, you're right. They're just checking total levels.
And that book is so archaic, right?
It is.
It's based on.
Well, old data too. It's based on like how, God, back in the day, they used to come in there and you get one big shot of testosterone a month.
That's what I'm saying. The ester of this drug dictates the timing. You see these doctors giving people testosterone recipient one shot every 2 weeks. Or God, I know I was a place one shot every 3 weeks.
Which is absolute insanity. And of course, they're making
on a
their
roller
clients
coaster,
come into the office.
Their estradiol's through the roof, and it's like.
Well, and a lot of them don't manage the byproduct. They don't manage the person. Like I said, you could apply it to you and you and you, and everyone's going to need a slightly different, maybe the aromatize different, sex hormone's going to be different. Yeah. It's like making sure whoever's going to manage it, that they're managing the person.
So another quick, because again, I know this is a long show. So topical testosterone, something you and me have never really embraced, and I know a conversation we had long ago was that it was a very high degree of risk for dihydrotestosterone conversion.
Correct.
It created more prostate problems, hair loss, and cardiovascular disease. And that was actually a New England Journal of Medicine entry that kind of happened that was kind of shunning testosterone. And then they had to redact it because they figured out it was only topical and that they couldn't prove that injectable was part of that. So what is your message to guys that are out there who are concerned about, I don't want to take shots and maybe topical is my solution, or my doctor who doesn't know anything about testosterone advised it because they think it's the safest thing to do? Why would you suggest that be the absolute opposite in the most dangerous way?
Well, in what Alex was talking about, so testosterone converts into two different hormones, dihydrotestosterone and estrogen, and that's done by mediated two different chemicals. Estrogen is converted via aromatase, and then testosterone to DHT is by 5-alpha reductase. Well, there's a very high concentration of 5-alpha reductase in our skin. So when you rub topical testosterone on the skin and it's absorbed through the skin, the 5-alpha reductase in the skin converts the majority of testosterone into DHT, which is actually the anabolic drug Winstrol, which is banned in the Olympics and known to cause all sorts of problems because it's pure DHT. So this is why we never recommend doing topical testosterone, because all the clients that when we first started, analyzing and thinking about doing hormone replacement therapy, we started seeing these sky-high DHT levels in clients that were doing topical testosterone. And this was back in 2006 before anybody knew that topical testosterone was bad for you. And of course, it adversely affects your lipid profile, adversely affects your prostate, makes your hair fall out. I mean, all the things. I mean, anybody that has any problems with hair loss, they know what DHT is. They just talk about it all the time. Block DHT, block DHT. And that's because DHT is a primary cause of acne, hair loss, prostate problems.
But then you got those doctors out there overprescribing finasteride because, hey, saves your hair, but now you feel like shit and you don't have sex and your dick doesn't work.
So they're causing problems on top of that. So, I mean, if you can't, if you're totally averse to injection, they do have the new oral testosterone out.
Kaisertrax, yeah.
And the way that the oral testosterone works is actually a novel, just an amazing technology. They actually found a way to encapsulate the testosterone molecule in a liposomal shell. So when you swallow the testosterone pill, it's actually absorbed into your lymphatic system, does not go through your liver at all. And it's absorbed through your lymphatics and then is dumped into your venous system. The lymphatic system drains in your venous system in a port called the thoracic duct that's up in your left shoulder into your subclavian vein. And it jumps right into your venous system and then circulates throughout your body.
Yeah.
So you have to take it twice a day.
That's the problem.
It's way better than doing topical because it is a pure form of testosterone that has not been affected by 5-alpha reductase or aromatase. So, and because it's shorter lived, it actually doesn't have as much time to convert into either one. But yeah, you have to take it twice a day. That's the only downside to it. But I mean, for people that are adverse to injections, yeah, it's a great way to go.
Keep fertility too.
Yeah. It actually reduces, it helps to minimize reduction.
We've talked about Kaisertrax on the show, and I tried it myself personally. We have a few patients, of course, that had issues like elevated blood pressure or polycythemia that just was unmanageable, or their PSA kept coming up every time they took a shot of test. And it was a great option aside from just no option. Do I think it's equal as far as the quality results to injectable testosterone? No, because you're only exposed to testosterone for a few hours a day, where we're exposed to it for 24 hours, 7 days a week, and so we get these androgen benefits and testosterone benefits.
Correct. Yeah, absolutely.
But we also get some of that.
But for patients that just are unwilling to do injections, I think it's a nice alternative. But injectable testosterone is still the ideal, still the baseline.
Interesting. Well, I got one question before we finish it up. You've touched on a lot in this episode about the impact of genetics onto heart health. That's the biggest indicator.
Correct.
Outside of knowing our family history, is there anything that is out there for genetic testing that we can do?
I mean, unfortunately, not for heart disease yet. Obviously, it'd be outstanding. They have obviously some cancer genomes you can test for, but there's nothing out there for atherosclerosis.
There's no gene mutation that makes you more susceptible to this, that you could do some genetic testing?
Unfortunately not. I mean, all we can do is look at family history as sort of a surrogate, for determining whether or not you might. But I mean, I've seen patients that literally have horrible family histories that have no atherosclerosis, and then patients that have no family history and they're the black sheep and they're full of atherosclerosis. So to sit there and say, let's look at my family. Yeah, that's why I'm like, get the scan done. I mean, obviously it's not 100% where it's like, if you have no risk factors, don't get the scan till 50 and you come up with atherosclerosis. It's like, there's no 100% in medicine, unfortunately, but it's much, much better than going off of what we're currently doing, which is, you got high cholesterol, take a statin drug.
Yeah.
Which I think is insanity personally. It's like, you need to sit there and treat each individual patient based on what's going on with them. And the heart scan takes so much of the guesswork out of finding and treating atherosclerosis, because the most important thing is making lifestyle changes, because we're all pretty healthy guys, but you look at average Americans, they're pretty bad,
pretty below average.
They're pretty bad, and so everybody's walking around just doing their thing, just like waiting, I guess, for their first heart attack to happen.
People wait till it's too late.
Well, they always do.
Nobody wants to be proactive,
and unfortunately, this is the failing of our medical society, because you go in to see your doctor, he's like, you can lose a few pounds.
People are reactive.
Cholesterol's okay. Right? Yep, see you next year, sort of thing.
Also, cure is more profitable than prevention.
Don't get me into that mess. Because there's no money in cures.
Yeah.
There's only money in treatment.
Treatments.
I have to cap off one final question, and I know it can be a controversial question, but for those who may have taken the injection that we all knew happened several years ago,
that not many of us had a choice in.
And for those who decided voluntarily or forced into it, the risk of myocarditis, the risk of blood clotting disorder, sudden death, if whether you believe that's the case or not, is there anything that those folks can be doing right now to potentially limit their possibilities for myocarditis down the road?
Yeah.
Or is there what?
I mean, there's really not. I mean, whether you
Once
had
it's in you, it's in you.
Yeah, once you had COVID or you got the vaccine, you're basically, you have the spike protein in your body, and how it end up affecting whether it's, your heart or the way your clotting cascade is functioning. Those things are in you. Now, I mean, typically, if you have not developed myocarditis, in the past 6 months after contracting COVID or getting the vaccine, probably are not going to get it. Usually people that get myocarditis or developing a severe clotting issue after the vaccine is typically within, the first month. And I've had patients that have expired after getting the COVID vaccine, primarily from thrombosis and pulmonary emboli, and that's happened within weeks of getting the vaccine. So yeah, it's one of these things that, if you got the vaccine, again, we will not know the long-term consequences of the vaccine for years.
Well, probably not at all, because it feels like
I think the big issue is going to be fertility, because we don't know honestly how the spike protein affects testicular function or ovarian function, because they definitely have found the spike protein in testicular cells and in ovarian cells.
Hey, but stop you from getting that flu,
Yeah.
Yeah, I mean, sometimes the cure is worse than the disease. So
Yeah, I
it's
a lot of money in that one. Well, Brian, this is Dr. Arcement. This has been an awesome one. I'm sure
great.
everybody
I appreciate you inviting me over here to talk. I always love talking medicine, so it's been fantastic.
Thank you, and it was great meeting you. And guys, make sure you subscribe to ManLab if you haven't already, and mention the ManLab for 10% off your first package with T-Clinics. Go to bit.ly/T-Clinics USA. Links in the description. See you next time.
Peace.